Hi, and welcome to the last episode of SWESEM Junior's ECG Essentials. My name is Julia. I work as a junior doctor in Stockholm, and I am also the chair of SWESEM Junior. And today I will be talking to you about electrolyte disturbances, as well as medicine toxicity and its effect on the ECG. So in med school, I remember being taught that the electrolytes interact in a very intrinsic pattern in the myocardial cells, causing the heart cells to either pump harder or less hard, and causing them to become stable or less stable. So in this first picture, what you can see is essentially a very, very schematic picture of how electrolytes interact in a myocardial cell. So the square is supposed to represent a myocardial cell, and what you have there is the sodium-potassium pump, which most of you will probably remember with horror, and also the sodium-calcium exchange channels. So the image is partly to remind us that potassium, calcium, and sodium all play an important role in the myocyte's action potential. Now, during the myocyte's depolarizing phase, it starts with sodium flooding into the cells. When the sodium reaches its peak concentration, calcium will start to enter the cells slowly, and potassium will finally exit the cells. This is part of the depolarization phase. Now, what I have drawn in my fantastic paint skills is the repolarization phase. That is to say, when the sodium-potassium pump uses energy, such as ATP, to pump potassium back into the cells, as well as pumping sodium out. Now, during the depolarization, we also got an intracellular increase in calcium. So, we need to get that out, and that happens through the sodium-calcium exchange. So, what I want to focus on first is the effects of hypokalemia on the heart. So hypokalemia means that we have a decreased amount of potassium in the extracellular fluid, and since potassium works as a stabilizer of the myocardial cells, we will consequently get an increased excitability of the myocardial cells. This mostly shows an increased excitability in the ventricles, but can also show us increased excitability in the atrial cells. So what does this actually mean for our patients? Well, what it means is that if the potassium level is very low, then their heart will be more prone to arrhythmias. These can be in the form of VT, VF, or even torsade de pointes. If we look at this first ECG, you can see a patient that is going into torsade de pointes, and this is a patient with very severe hypokalemia. This isn't the traditional signs that we see in an ECG of a patient who presents to RED with hypokalemia. If we go to the second ECG though, you'll see the more classical signs of a milder hypokalemia. What we see is an increased amplitude and length of the P wave as the atrial cells react more strongly to the stimulus of the sinus node. The PR interval is classically prolonged due to this. The T wave that we see in this ECG is inverted. It can also simply be flattened, and it is, as in this case, typically followed by a U wave. These are best seen in the precordial leads, and they give the impression of that we have a very long QT interval, but what we're actually looking at is a very long QU time. If we go to the other extreme, moving from hypokalemia to hyperkalemia, we get, logically enough, the reverse effect. Instead of having an increased excitability of the myocardial cells, we instead get a decrease in the excitability. This is also predominantly in the ventricles, but to a certain extent also in the atria. Depending on the severity of your patient's hypokalemia, you will get different signs on your ECG. The subtle signs of the milder hypokalemia will show as the reverse of what we see in hypokalemia. So flattened P waves, and these will flatten to the point of obliteration in more severe cases. And instead of having flattened or inverted T waves, Patients with hyperkalemia tend to have peaked T waves. This is commonly described as the earliest sign of hyperkalemia, and it is what we see in this first ECG. Because we have a tendency of the P waves to flatten and the excitability of the atria to go down, the interval of the QRS complexes can become prolonged. What naturally follows when the heart doesn't get impulses from the atria is an active escape rhythm. This can be either from the AV node or from the ventricles themselves, and quite naturally we will get different appearances depending on if we have a junctional escape rhythm or a ventricle escape rhythm. In very severe hyperkalemia, we get something that is called a pre-terminal rhythm. This is what we see on this ECG. Down the bottom, in lead 2, we have what is called a sine wave appearance. It's usually followed quite soon after by cardiac arrest. The classic patient to present with a hyperkalemia quite so severe is someone with severely decreased kidney function. So someone with a severe kidney failure who regularly goes to hemodialysis but might have skipped a session. So I had a patient who presented with a potassium of 9 at triage. His first ECG started with peak T waves, and he was quickly rolled into the resus room. Now, his ECG progressed quite quickly into a sine wave appearance, and when calling my consultant, who is potentially the calmest person ever, she slammed the phone down, and I don't think I have ever seen her run quite so fast. Thankfully, the patient did very well and did not end up in cardiac arrest, but it was quite scary at the time. When talking about electrolyte disturbances in general, disturbances in potassium is regularly what is most clearly associated with adverse events. We're going to move on to talk about hypocalcemia, which, even though it can cause some disturbances on an ECG, rarely has adverse effects on our patients. A low serum calcium will traditionally cause an increase in QT time, primarily by prolonging the ST segment. Now, when talking about a long QT time, we all know to worry about torsade de pointes, and these patients can go into torsade de pointes, but it is not very common. And when looking at this ECG that we have in front of us, we do in fact have a prolonged QTC. It's about 500. But you can see the PQ time is normal, and the QRSs also look normal. So this is a classic ECG for hypocalcemia with a prolonged ST segment. Hypercalcemia works in the opposite direction, also logically enough, and reduces QT time by a shortening of the ST segment. In severe hypocalcemia, we can see something that is called an Osborn wave or a J wave, which is noted on this ECG, and I think it is best described as a dent in the R wave. With extreme hypercalcemia comes a risk of ventricular irritability, and VF arrests have been noted, although, as with hypocalcemia, it is less common than with potassium disturbances. Now, our third important electrolyte in the myocardial cells is sodium. We're not going to talk about this specifically, but we're going to talk about it instead in view of medical toxicity. So there are tons of medicines that have adverse effects on the heart cells, but I have picked the ones that are most common and probably also most known for having such effects. So what I want to talk about first is the tricyclic antidepressant, or TCA. This is a medication that acts upon the sodium channels and blocks them. TCA is very well known for its cardiac toxicity, and even though the trend is to move more towards SSRI or SNRI in treating depressed patients, there are still quite a lot of patients who receive TCA. And if you get a patient coming in who says that they have taken too much TCA, or where you have reason to suspect such, I would say getting an ECG is one of the first things you should ask your assistant nurse to do while you go through the ABCs. Now, TCAs work as a general depressant on myocardial excitability, By blocking sodium channels. They block sodium channels in the brain and heart, so if you have a patient with very severe intoxication, you might not only see ECG changes, but also seizures. Because of the decreased excitability of the myocardial cells, you will generally see widened QRS complexes. This is because the impulses travel slowly through the myocardium. Because you get a secondary inhibition of the sodium-potassium pump, you will also see a decreased QT interval. Despite the general inhibition of the myocardial cells, the sinus node becomes disinhibited and your patient will present with tachycardia. Now, the next medication I wanted to talk about are beta blockers, and I also threw in calcium channel blockers there because they have the same effect on the heart and the ECG when taken in toxic levels. Now, beta blockers and calcium channel blockers work as general depressants. This means that they depress the sinus node, the AV node, and the myocardial cells, and depending on toxicity will cause different effects. Now, in this first ECG, we have a patient who has a sinus bradycardia with a heart rate of 45 and also an AV block type 1. As toxicity gets progressively worse, the sinus inhibition will become even stronger, eventually leading to a sinus arrest, which can be seen in this ECG. Here we have no P waves visible and a slow junctional rhythm. We know this because the QRS complexes are still narrow, but the beats per minute is 30. Now, moving on to my third example ECG, here we can see P waves, but they have no correlation with the QRS complexes. Thus, we have an AV block type 3 with a sinus rhythm of about 90 and a ventricular escape rhythm of about 30. This means that the atria and the ventricles beat irrespective of each other. And summing up toxicity by beta blocker or calcium channel blockers, we get a general inhibition which can cause sinus bradycardia, an AV block of varying degree, a sinus arrest, and a junctional or ventricular rhythm. The last medication I want to talk to you about is probably the classic, known for its positive effects on the heart but also negative, and that is digoxin. Digoxin is a medication that we use to slow the AV node at the same time as increasing the inotropic effect of the myocardial cells. So what we use digoxin for is primarily for people who have a fast atrial fibrillation or atrial flutter. By decreasing the activity of the AV node, we will slow the ventricular rhythm in these patients. And by increasing the inotropic effect of the myocardial cells, we will increase the contractibility of the ventricles, thus giving a better cardiac output. In digoxin toxicity, this goes to the extreme, where the AV node is inhibited to such an extent that we get an escape rhythm. This is also because digoxin in higher concentrations increase the automaticity of the myocytes. And where we in non-toxic doses get a positive inotropic effect, in toxic doses this creates an unstable, overly excitable membrane. Now, when looking at the ECG, we can see a fast supraventricular rhythm with a prolongation of the AV time and premature ventricular complexes. When looking at this ECG, I think that the most clear picture is that we have a combination of supraventricular and ventricular complexes. Now, digoxin, even in non-toxic doses, creates some ECG changes, and these are generally described as a biphasic T wave, or what is also called a Salvador Dali mustache sign, as you can see on the picture. If you get an ECG looking like this on a patient with digoxin, you don't need to fret. But if you are intending to increase the dose of digoxin or give the patient more, you might want to get a concentration before you do so. And to summarize, I think it's important to remember that those 3 little electrolytes that we talked about during this lecture have a very strong impact on the heart when put out of balance. Not only because of the number on your lab test, but also because of how different medications affect these electrolytes and through those cause their adverse effects upon the heart. If you want to read up on this lecture, please do check out the lecture notes where you'll find all the information about what I've talked about here, and as a bonus, also a short introduction to pacemaker rhythms and what special considerations you must have when looking at an ECG of a patient who has a pacemaker. Thank you very much for listening, and I look forward to seeing you all in Copenhagen in July.